everyone. We are going to get started. This is Andrea Giovannucci from IASP. I would like to welcome you to today's webinar on pain in children. Today's webinar is the first in a series related to the 2019 Global Year Against Pain in the Most Vulnerable, and is sponsored by the IASP Special Interest Group, Pain in Childhood. Before I introduce our moderator, I wanted to bring your attention to some information that appears on these slides. There are several ways to participate in the webinar today. After the talks, we will have a Q&A session, and you can type in your questions into the Q&A area of your Zoom meeting control panel window. You can submit questions at any time that you would like. We will also be sharing the event on Facebook, and you can share our Facebook video on the IASP Facebook page with friends and colleagues. You can also do some tweeting at hashtag GYPainVulnerable and hashtag IASPWebinar, and follow at IASP Pain on Twitter for live updates. I have the pleasure of introducing our moderator, Liesbet Goubert. Dr. Goubert is full professor in the Department of Experimental Clinical and Health Psychology at Ghent University, Belgium. She's interested in psychosocial risk and resilience factors that impact the development of chronic pediatric pain and in the interpersonal dynamics of chronic pain and chronic illness. She's a council member of the IASP Special Interest Group on Pain in Childhood and is a member of the 2019 IASP Ethics Task Force, Global Year Against Pain in the Most Vulnerable. Welcome, Dr. Goubert.
Thank you for the introduction, Andrea. Welcome, everyone. It's my pleasure to introduce my fellow faculty. We have two distinguished speakers today who will talk about childhood pain and irritability, Dr. Tanja Hechler and Dr. Harold Siden. I would like to welcome you both and express my thanks for your willingness to share your expertise with us today. Our first speaker today is Dr. Tanja Hechler. Dr. Tanja Hechler is a full professor of clinical psychology and psychotherapy for children and adolescents at the Department of Psychology at the University of Trier in Germany. She is the head of the outpatient clinic for children and adolescents with a focus on the treatment of chronic pain and emotional disorders. And she is also the head of the postgraduate training in child and adolescent psychotherapy. Her key research areas are chronic pain, interoception, and emotional processes in children, adolescents, and their caregivers. Today, Dr. Hechler will be speaking on detrimental effects of emotional distress on treatment outcomes in children with chronic pain and their caregivers, a call for action in science and clinical practice. Dr. Hechler, the floor is yours.
Thank you very much for this introduction, Liesbet. I'm very happy to give this talk on detrimental effects. I'd just like to show you where I'm located. Trier is actually the oldest city of Germany. You can see some photos on the right-hand side, and you also see some photos of our department. Detrimental effect, actually, yeah, I've got no conflict of interest to declare, and my funding is displayed on my last slide. What I would like to start off with is really the reason why I'm studying this issue. I'm going to present you studies on the adverse effects of emotional distress on treatment response in adolescents with chronic pain. And I'm presenting you two studies who looked into the most intensive form of treatment, that is intensive interdisciplinary pain treatment. The first study I was involved in when I was working with the people from the German Pediatric Pain Center, we assessed 167 adolescents pre-treatment, 3 months and 12 months post-treatment. And we defined various outcome groups, such as cured, long-term improved, short-term improved, that these are those that deteriorate over the course, and those with unsuccessful treatment. And if you look how the adolescents distributed to these groups, you can see that the majority, that is 60%, had a good outcome, but there were also 19% with short-term improvement and 22% with unsuccessful treatment results. And the next question is then, what are variables that are actually associated to these outcome groups? And when we did the analysis, what we found, among others, is that short-term improvers, that is those that deteriorate over time, display increased depressive and anxiety symptoms at baseline. Laura Simons published a very similar study last year where she assessed 235 adolescents who are also undergoing intensive interdisciplinary pain treatment. she looked at pain trajectories over various time points, and this is what she found. You can see on the y-axis the average pain level, and on the x-axis the different time points. And if you look at the green line, you see those that we want to see, that is the early responders, the blue line are the late responders, and the red line are the non-responders. And what she found in her study, among others, is that an increase in anxiety symptoms was associated or increased the odds ratio of being a non-responder. So both studies show, even if we look into the most intensive form of treatment, we see adverse effects of emotional distress. And that is really the reason why I'm looking into that issue. And I'm focusing on a particular type of emotion, that is the fear of internal bodily sensations. And to start off with, I like to ask you, you do not need to answer, what are you frightened of? Are you frightened of medical procedures? Are you frightened of getting assaulted? Or would you get frightened if you feel a sore neck, or if you have like a stomach rumbling, if you feel like a stomach rumbling? Do you get frightened when I read the following script loud out to you? I feel a slight tension in the middle of my stomach. I can also feel a prickling in the middle of my stomach. I show you within the next slides that we found evidence that adolescents with chronic pain react fearfully to bodily sensations when they are provoked, but also when they only imagine these sensations. So the first study was a study where I received a grant of the University of Witten-Herdecke, and I worked together with Christiane Panet-Faré from University of Greifswald. What we looked into was self-reported fearful reactions following the provocation of interoceptive sensations in adolescents with chronic pain. And how do you provoke internal bodily sensations? We decided to use muscle tension tasks within a group of 20 adolescents with chronic abdominal pain and 20 adolescents with chronic headache. And we asked them to perform various tasks. And here are the two tasks that we used. The first task was to tighten their abdominal muscles, which we considered proximal for adolescents with chronic abdominal pain. The second task was to frown, so to tighten the musculus corrugata supercilii, which we considered proximal for adolescents with headache. And we had a safe comparison task that was clenching the fists. And we asked them to report their fear levels after these tasks. And I'm showing you results for fear and avoidance in this sample. Here are the results for fear. You can see on the y-axis self-reported fear, and on the x-axis the three tasks. The gray column are adolescents with chronic abdominal pain, and the black ones those with headache. And what you can see clearly is that adolescents with chronic abdominal pain report increased fear after tightening their stomach. If you look into avoidance, you see a very similar pattern. Adolescents with chronic abdominal pain report increased avoidance after tightening their stomach. And if you look at those with headache, you can see that they report increased avoidance after both tasks. So this study shows increased self-reported fear and avoidance following the provocation of locally proximal interoceptive sensations, particularly in adolescents with chronic abdominal pain. In the second study, which is an ongoing study, I received a fund from the German Research Association. I worked together with Silvia Schneider from Bochum and Christiane Panet-Faré, and we extended our research question. We wanted to not only report self-report of fear, but also to have a parameter for the defense response mobilization of adolescents. And a good parameter is actually the eye blink startle response, which is potentiated in threatening situations. And what I'm showing you here is the imagery part of the study. So what we wanted to know is, or we wanted to investigate, if adolescents with chronic pain will display increased defense response mobilization, that is startle potentiation, during the imagery of sensations typically associated with the main pain. And how did we design these imagery tasks? We ask adolescents to report sensations which they usually feel prior to their pain, and then we put these sensations into imagery scripts. So we had pain-specific scripts for head and stomach, like I have a very tensed up neck and head. I move my head, but it doesn't change the tension. I feel a slight tension in the middle of my stomach. I can also feel a prickling in the middle of my stomach. And we compared these scripts and the startle potentiation to standardized fear scripts, such as taking a shower alone in the house, I hear the sound of someone forcing the door and entering the house, and a neutral script, like I'm looking at the trees in front of me, I see leaves moving in the wind and birds flying past. And I'm showing you preliminary results of a sample of 34 adolescents with chronic abdominal pain and 50 adolescents with chronic headache. Here you see the mean startle response on the y-axis, and then you see the data for chronic abdominal pain and chronic headache over the 3 imagery scripts. And what you can see clearly is that we found a stronger potentiation of the startle reflex after pain-specific scripts and after fear scripts. So this part of the study shows that adolescents react fearfully with an increased startle potentiation only when they imagine internal bodily sensations. I think both studies clearly call for clinical application, and in anxiety research, we have a very potent intervention that is interoceptive exposure. That means that you confront the adolescents repeatedly with feared internal bodily sensations, and with the assumption that an inhibitory learning process will occur. That means that the adolescent learns that this internal bodily sensation is no longer indicative of the fearful event. And I want to show you what is state of the art of this intervention in chronic pain research. The father, if you want, of interoceptive exposure is Dr. David Barlow from Boston University, and he has written a very nice overview of this intervention. And if you read it, you conclude that very few studies have investigated the efficacy of interoceptive exposure in adults with chronic pain, and even fewer in children and adolescents with chronic pain. And of importance, we have 2 forms of interoceptive exposure. We can either use symptom provocation tasks, for example, ask adolescents to tighten their stomach, or we can use interoceptive exposure in sensu, so that we ask adolescents to imagine, for example, increases in pain intensity. What is state of the art of interoceptive exposure in children and adolescents with chronic pain? Well, I can give you 2 words about that. There are very, very few studies, and the studies that exist are highly heterogeneous. Let me show you this. Here's a summary of all studies. I don't want to bore you with this, but I'd just like to highlight the heterogeneity within some aspects. The first aspect is the sample that have been investigated, ranging from various sample sizes, but also from various age groups that have been investigated. Most importantly, the studies vary in the form of interoceptive exposure, with some using in sensu interoceptive exposure and others using symptom provocation tasks of very different format. They differ in study design, and if you look at the results, this is no meta-analysis, you see that there are promising results. There's only one study that didn't show a clear positive finding, but I think, to summarize, we have a potent intervention to decrease fear of internal bodily sensation. We have 2 forms of interoceptive exposure, but at this stage, I cannot give you any clinical recommendation due to lack of studies and their heterogeneity. And this is my call for future research into interoceptive exposure. I think we really need to look into causal effects of the 2 forms of interoceptive exposure in individual cases of adolescents with chronic pain. And I think we have a very potent design to do that. And Richard Wixel and Johan Flein have just held a conference on this design, which is single case experimental designs, meaning we use a very small group of adolescents. We assess them at baseline. We have very dense data on each individual. Then we give the intervention, we take it away, and we can look into causal effects of the interventions. And I've just put in a grant, so I hope I can tell you more about this within the next years. Coming to the second part of my talk, if you talk about adolescents with chronic pain, you cannot not talk about the parents. So the second part of my talk is on parental reactions to children's pain of parents with chronic pain and anxiety. So this part is really about the emotional distress of the parents. And why I'm interested in this, I would like to show you within this study I did together with the people from the German Pediatric Pain Center. This study was a randomized controlled trial on intensive interdisciplinary pain treatment funded by the Robert Bosch Stiftung. But what we did in this study was we assessed 40 mothers and fathers at various time points to investigate parental reaction to children's pain following intensive interdisciplinary pain treatment. And I would like you to focus on the solicitous behavior response of the parents, and I show you what we found in this sample. So the question in this research was, which changes did we see in parental behavior following the treatment, and which factors actually modulated the change in parental behavior? So what you can see on the y-axis is the questionnaire with which we assess the parental behavior. I just want you to look at the dotted line in the upper part of the figure, and the squares represent the fathers and the triangles the mothers. And what you can see is mothers and fathers did not differ. They showed a similar pattern. That means a decrease in solicitous behavior across the time points following treatment of their children. What we also found that parental catastrophizing had an impact on this change. The more parents catastrophized at treatment beginning, the less they decreased solicitous behavior. The more they reduced catastrophizing over the course of assessment, the more they decreased solicitous behavior. And I think, to summarize, so we see a decrease in maladaptive parental behaviors after treatment of the child, but we also see an influence of parental catastrophizing. And this is why I decided to study this construct together with other research groups in more depth. So the second project I would like to present you in this area is a project on parental reaction to children's pain, the role of parent and child chronic pain and anxiety. And we're working together from people from the UKA in Hamburg. What are the research questions of this project? I wanted to study adults with chronic pain and anxiety symptoms and their children, and I wanted to look into the variance of parental catastrophizing in this sample, with the hypothesis that the greater or the more severe the symptoms of the parents, the more they would catastrophize. But I would also expect a moderating effect of child's variables, that is, child's chronic pain and child's anxiety symptoms. And what we did, we assessed adults either via self-help forums or in specialized hospitals with chronic pain and anxiety symptoms. And we were able to recruit 118 parents with chronic pain. And displayed here is the severity of the chronic pain stage via the Mainzer Stadien concept. So the higher the stage, the more severe the chronic pain problem. And what you can see is that 60% are in a very high stage of chronic pain. Here's data on parent anxiety symptoms using the DAS scales. What you can see is that 29% had clinically relevant values in depression, 37% in anxiety, and 43% in stress. So they were emotionally distressed. We asked parents to report symptoms of their children, and they reported on 190 children. They reported chronic pain and anxiety symptoms using the scale. And what did we find when we did that? 31% of the children, according to their parents, suffered from chronic pain, and more than 50% suffered from clinically relevant anxiety symptoms. This is worrisome. What did we find regarding the variance in parental catastrophizing and the role of parent and child chronic pain and anxiety? We found, and I think this is interesting, that parents with more severe chronic pain catastrophized less than parents with less severe chronic pain. That was unexpected. And we also found in line with other researchers that the more parental anxiety, the stronger they catastrophize. And what about child variables? We found that child variables, child's chronic pain and anxiety, did not have an influence on parental catastrophizing. So what can I summarize about these projects? If you, apparently, this is in line with other research groups, if you assess adults with chronic pain, you see that their children seem to suffer from chronic pain as well as from anxiety symptoms. And we talk about the familial transmission of chronic pain in this area. You can also see from our study results that there is clearly a variance in parental catastrophizing, but according to our data, it appears that it's more the parental variables like chronic pain and anxiety symptoms that exert an impact rather than the children's symptoms of chronic pain and anxiety symptoms. What do these studies call for clinical application, or what are the clinical application of these studies regarding the issue of parental reaction to children's pain, parent chronic pain, and parent anxiety symptoms? I think I would like to draw your attention on two topics, and I mentioned excellent publications here on this slide. And there are also other research groups who work on this salient topic. If we look into children with chronic pain, I think it's pretty clear to everyone that we need to assess parental variables and we need to include parents into treatment if we treat children with chronic pain. I think this is not something new, I'm telling you. And there are excellent works out there. What I would call for really is to do the same thing the other way around. That means if you treat adults with chronic pain and or anxiety symptoms, my recommendation would be to assess child and parental variables. And I think the next step clearly should be to include interventions for both parents with chronic pain and their children, such as educational modules, to decrease, for example, misconceptions about the parent's chronic pain, and maybe that this way decrease emotional distress of parents and their children. So let me summarize, and then I think later we can discuss these topics. I've shown you the adverse effects of emotional distress on treatment response in adolescents with chronic pain, even when we look at the most intensive form of treatment. I've shown you the role of fear of internal bodily sensations. I presented you data that adolescents are frightened when you provoke internal bodily sensations or when they only imagine internal bodily sensation, which calls for interventions such as interoceptive exposure. But at this stage, there are way too few studies, and I cannot give you any clinical recommendation at this stage. I've shown you data on parental reaction to children's pain, particularly parental catastrophizing, in a group of parents with chronic pain and anxiety, where I could show you that there is variance in parental catastrophizing and that it's more explained by parent rather than by child variables. And my recommendation would be, please assess child and parent variables, even if you treat adults with chronic pain and anxiety. This is my last slide. I'd like to thank all the people that were involved in the research project, first and above all the doctoral students, Florentina Flack, Luca Schan, Piotr Gruska, Maren Frerka, all my cooperators from various universities, the research assistants, and I've depicted the funding for the research projects on this slide as well.
Thank you very much, Dr. Hechler, Tanja, for your very interesting presentation. So attendees can submit questions for Tanja through the Q&A box at the bottom of your screen. But now I first would like to introduce our second presenter, Dr. Harold Siden. Dr. Siden is the medical director at Canuck Place Children's Hospice in Vancouver, Canada. He is also an attending physician in pediatrics and medical director of palliative medicine at BC Children's Hospital and an investigator in the BCCH Research Institute. Furthermore, he is a clinical professor in the Department of Pediatrics at the University of British Columbia. His clinical interests are pediatric palliative care, pediatric pain management, and general and complex care pediatrics. Dr. Siden will be speaking today on pain and irritability of unknown origin in pre-verbal and non-verbal children. The floor is yours.
Thank you very much, Liesbet, and good morning, or I should say good day to everyone on the webinar. Just going to make sure that my slides are, there we go. Let's see if this is capturing. Coming there, there we go, sorry. So these are my titles as Dr. Goubert just introduced me, and I'm going to be speaking about the following objectives today. which is something that I think some of the listeners are very familiar with, which is pain and irritability in children who cannot tell us, report what the pain is like. So very unlike Dr. Hechler's young people who can tell us in great detail about their pain, this is a population that we see showing pain-like behaviors, but we don't exactly know where. I'm going to talk about the variability in treatment and an assessment and a new study that we're undertaking currently. I have no conflicts of interest, and I may be describing the use of medications off-label in this talk. So the problem, and I'm not going to read these slides out loud to you, but the problem is that we know that children with significant neurologic impairment experience pain, and they display pain-like behaviors. And the reasons for these are often unclear. It's ambiguous, and parents and caregivers spend a lot of time trying to decipher the language of the child and what these behaviors mean. And we also see that they receive, and I'll show you some evidence for this, very inconsistent and ineffective care for this pain. So I use the term, which has been gaining a little bit of traction, significant neurologic impairment. And on the left-hand side, you can see some other words that we use around these, very inconsistently and sometimes inappropriately, but this is a child who has significant intellectual impairment. They may be, certainly are nonverbal, and may have some communication strategies that caregivers who know them very well can interpret, but it requires really deep knowledge of the child to understand. They're non-mobile. Often they cannot eat, or if they eat, they do so with a lot of assistance. We tend to use the term cerebral palsy with these children because they have cerebral palsy, which is a muscle and motor disorder, but it doesn't really describe what they have. And they are dependent on others for care. On the right-hand side, you could see many other conditions that go along with this. These are children who primarily either have brain injury or sometimes neurologic disease that's genetically based. So you'll hear me use the word SNI, or severe significant neurologic impairment, to describe these children as kind of an overarching code word, knowing that there are literally hundreds of different etiologies for how the child ended up in this state. So we also coined a term PIUO, and I'll tell you why we did this, which is that we see these pain-like behaviors, and I'll tell you in a minute why we don't know that it's pain per se, which is crying out with vocalizations. Sometimes there can be tears, there can be grimacing, and motor withdrawal. I'm going to take it as a fact that most of the listeners on this webinar, most of the participants on this webinar understand the IASP definition of pain. And the thing about this behavioral constellation that we see is that we cannot, or the challenge, I shouldn't say we cannot, the challenge is to identify a nociceptive or inflammatory etiology for pain in these children, which is what most of the investigations are directed to. Whereas there may be a phenomenon of a centrally driven or brain-driven series of behaviors that we would call irritability, which may, we don't know, but may feel like pain or may feel like some other form of agitation. And these children often have a very limited repertoire of behaviors, and they may look the same. So the behaviors are ambiguous and nonspecific, and that's why we chose to call it pain and irritability rather than saying we know that it's pain. So this is something that you all know about that central phenomenon that I referred to, which is that pain does not occur in one part of the brain, but is found across multiple centers. It is a highly coordinated alarm response to fear and to nociceptive stimuli. This is something that I teach the residents here. I talk about 4 types of pain. So this is pretty classic nociceptive pain. You hit the thumb with the hammer, and we have a deep knowledge of the kinds of signaling that occurs, and it almost always occurs with inflammatory pain. People wonder why I show polar bears with inflammatory pain, and that's because they like ice, and that's helpful when you have inflammatory pain. The two go together. A moment after you hit your thumb with the hammer, you'll have inflammation. There are some entities where you can have inflammation without nociception, such as chronic arthritis, for example. But the next kind of pain is the classic neuropathic pain. This is a slide from the American Civil War, because this is the first time that physicians begin to describe postoperative causalgia and neuropathic pain in great detail. And we continue to have examples of that. Now we have a much, much better understanding of what damage directly to a nerve will do and how that differs from the other two kinds of pain. But as we move down this ladder and we get farther away from useful animal models and human models, we then end up with functional pain. This is a image of a doctor from television whose name was House. Those of you who knew American TV, this was a character of a physician who, while he was a brilliant physician, had an addiction problem because of his neuropathic pain, or his seemingly neuropathic pain. And the term functional is not one that I like, but it talks about, it speaks to something that is happening elsewhere, some kind of central wind-up or central stimulus of pain that we cannot identify a classic nociceptive inflammatory or neuropathic source for. There's this very nice slide from Clifford Wolf. This was from 2004, and it shows you something that we know at the time about the underlying physiology of these four kinds of pain, with nociceptive pain having its signaling in the nociceptive sensory neurons. Inflammatory pain has the soup, the cascade that results from tissue damage with inflammatory markers. Neuropathic pain occurs with peripheral nerve damage directly and then abnormal signaling from that nerve. But the last one, this functional pain, this centralized pain, we really have very little understanding about. We're gaining more and more now with functional MRI, and that's very helpful. But I show this slide to correlate those four images, those four fun images, to something that we can say really has an underlying physiology. So I think our task with these children is to say, when we see children showing this kind of, and it could be adults, by the way, who are nonverbal. And in fact, I'm just going to throw this out, one of my interests is that we see a very similar phenomenon in older adults with advanced dementia. So it's not something that's only limited to the small child. But when we see these kinds of phenomena, we want to start thinking about, is it one or two or a mix of all of these kinds of pain? Because of course that helps us target further interventions and treatment. So again, thinking about pain and irritability, and you can see that the little guy on the right, and perhaps President Bush are having the same reaction. We hope that the baby is not experiencing actual nociceptive inflammatory pain, but he is certainly irritable. Whereas pain, according to that wonderful IASP definition, is either tissue damage or sensation akin to tissue damage. And this is again, something that the reasons are often unclear, and I've shown this slide previously. We have inconsistent care. This is a parent, and I love finding quotes from parents who describe eloquently. This was a woman from a British study. We felt that everything we tried was just a waste of time. It didn't help at all. We thought that she had pain all the time, that the pain was so bad that it was impossible to distract her from it. And further quotes from this qualitative study point to a lot of frustration with the health system, the medical system, and ineffective and useless intervention recommendations. These are parents who take turns of being up all night long with their children. This is a collection of all of the things that a clinician is often confronted with children with severe neurologic impairment and the interactions of them. And my colleague in Minnesota, Stefan Friedrichsdorf, put this slide together. And you can see on the left-hand side is pain, but these children have so many other physical health challenges going on. In the boxes on the very far right, IV medications, surgery, and seating and bracing are things that we do to children. So the children actually have external sources of nociceptive and inflammatory pain that we know about, and their reactions to those are very important. And these children are exposed to far more medical interventions than the typical child. So already we have stacked the deck against them. But in addition, on the left, with that highly interconnected set of circles, you can see all of the things that happen to these children that lead to kind of an ongoing pattern of pain and irritability. Dysomnia, by the way, is sleep deprivation or sleep disturbance. So again, and we all know, those of us who are studying pain as much as we are in children, that sleep and pain are highly, highly linked. So this is a moving slide of the usual evaluation. I didn't want to risk putting the animation on for the webinar, but Typically, H&P, for those of you who are not medical, stands for history and physical. The child goes to multiple doctors, who all of whom repeat the same physical examination. They are given x-rays. KUB is an abdominal x-ray, spine x-ray, so on. So one doctor takes blood, a different doctor takes a urine sample. Someone puts them on melatonin, someone else puts them on baclofen. And you can see it's a very kind of chaotic approach, with each time the parent thinking, oh, this will help solve the problem. When we studied this in our study of children, we had a cohort of 274 children with severe neurologic impairment due to various causes that we followed longitudinally for 3 years. And this was the Charting the Territory study. And the children were on, you can see the medications that they were placed on. And I will say empirically, because it's kind of just throwing drugs at the problem. 31% were getting acetaminophen at some point and a non-steroidal 17% of the time. 45% of the children were receiving benzodiazepines, but of course those can be used for both seizures, sleep problems, muscle spasms, as well as this kind of pain and anxiety. There is not a single study that really backs up the use of these drugs in this entity. The recommendations are primarily class 4 and class 5 evidence of expert opinion. And it's very, very difficult to design head-to-head randomized controlled trials for one drug compared to a placebo or another drug for this population. So we asked the question, and this is going back to 2010, we said, well, how would experts treat this child if we gave them a case vignette and said to the experts, you have an opportunity to treat this child. You're going to use medications first. Which is your very first drug to use? What is the second line drug, the third line drug? Very typical approach. And here's the answer, which is that we had 6 physicians but received 9 answers. And the point of the slide is to see that with the different colors, no one could agree on what the pattern was supposed to be for a first, second, or third line drug. So even these experts didn't really know how they wanted to approach this. So we designed a study, and our study was to study the sequence of drugs in children. And the criteria for coming into the study was that you had to have a child with severe neurologic impairment, and the bottom line is the child had to have been previously evaluated for the treatable causes of pain. So we wanted to make sure before we enrolled the children in a drug study of central pain, essentially, that we knew that they did not have renal stones or hip dislocation, et cetera. So not a single child who had been brought to the study after recruitment through community physicians had a full evaluation done. And I described the full evaluation here. And not one of these children had that full evaluation completed, even though the physician sent them to us for the study. And the bottom of the bullet says they were recruited through pediatrics, but they were already seeing an average of 9 subspecialty teams at our tertiary children's hospital. The range was from 6 to 14. So they're already seeing multiple subspecialists, none of whom can figure out what the cause of pain is. And that was really the most surprising. And that goes back to that slide with all of those colored squares and circles. So we did a study. This was just a small pilot of 8 children. And in order to do our drug study, we had to do the workup ourselves. So for 6 of the children, we completed a full workup. And you can see on the bottom that it gave us some very gratifying information that most of the children who had completed a full workup, we were able to identify before enrolling them in the drug study a cause of pain that had not been identified by these 9 other subspecialty teams. And that was kind of an aha moment for us at the time, which led us to think really what we needed to do was have just a much more efficient and focused management plan for evaluating and then treating pain in these children rather than worrying about the medications. And that led us to this particular study. It is funded by the Canadian Child Bright Network, and it is called Optimizing the Management of Pain and Irritability in Children with SNI. The reason that we did this study is it's really almost more of a health services research study, which is if you can get people to follow a very focused clinical guideline about pain in these children, you can actually uncover much of the time the cause of pain and irritability that's not really centrally driven, but is something that you can actually treat for nociceptive inflammatory causes. It is an attempt to move from unknown causes to known causes. It is done as a randomized waitlist controlled trial in 4 centers, which are listed here from Vancouver to Ottawa. And these are being conducted now by not the most expert of pain physicians, but very experienced complex care, palliative care physicians, because we're trying to move it from the level of the originators of this to the next level out. And we're just starting recruitment this year, but we're hoping to eventually get 120 subjects over the course of the study. So it really does 2 things. It has a step 1, which is a very, as I say, focused history and physical thinking in terms of wearing a pain lens, if you will. And then anything you do from that might be an evaluation based on what you find. So for example, if you find bleeding in the gums, you might ask for a dental referral. If you find a hip that is very sore, you might get a hip x-ray. But if none of that reveals anything, then there's a series of screening tests of things that you wouldn't normally be able to tell. So we look for urinary tract infection. We look for the acidity of the stomach. We would do an abdominal pelvic ultrasound. So these are things that I can't tell just with my history and physical in the clinic. The other very important is the last bullet again, which is that there's frequent contact with the physician and nurse on the team. And in fact, the nurse is really available at all times, 5 days a week, to talk to the family, whether it's by email or phone. Because we found that in our pilot, the parents reported that that was one of the most valuable parts of their working with the team and helped them come up with a solution. So we're actually studying how does the nurse interaction work. So the outcomes are 2. The main outcomes of the study is we simply ask, is the pain and irritability better, the same, or worse? We're using very simple questionnaires around that. But I'm also very, very interested, and this actually goes back to Tanja's previous talk, which is what happens to parent stress. My primary marker for parent stress is using the Promise 57 tool, but I'm very, very interested in parent sleep, although other markers are there as well. And it's interesting to think, how does parent stress play a role in children's pain in nonverbal children in the same way that it may be playing a role in very verbal adolescents. This is just a slide of showing you the relatively complex study design, but it's, as I said, it's a relatively simple approach to this problem. And someone has already asked a question online, and I hope this question answers it. The study that we're using, the tool that we're using for the study is the very first tool, the non-communicating children's pain checklist, or the NickPick as we call it. Dr. Lynn Bro, at the time she was in Halifax, developed this tool. It's been well studied and validated. Dr. Ann Hunt in England developed the pediatric pain profile, the PPP, and did a lot of work on this in the 90s and the early 2000s, but has not done a lot of work since. We are also using the FLAC, the revised FLAC, which was originally a postoperative pain scale. The last scale that we're not using in the study is the pain indicator for communicatively impaired children. This was also developed in Britain in the 90s, but has not had a lot of press since then. But for those of you who are interested in pain scales, these are the ones I refer you to, and I will talk in the question period a little bit more about those. But we are using the NickPick and a survey tool that we designed just for this study for the purposes of the PIUO study. This is just an example of what the NickPick looks like. It's got 30 behaviors, and they're scored by category. And they give you the kinds of behaviors we see in these children. Change in their eyes, turning down the mouth, less active, floppy or stiff, shivering, sharp intake of breath. So these are not verbally reported, oh, it hurts here. This is the kind of behaviors that a parent would know and look for. So, and the PPP, the pain profile, has a similar set of stems or triggers for the families. There's a copy of the pain profile. So again, it shows you grinds teeth, flexes inwards, tends to rut or tub, pulls away, etc. While we were undertaking the study, as we began, Amy Houtro, Julie Hauer, and a very large section of the people in the palliative medicine and children with disabilities, the American Academy, have published some guidelines. Their guidelines look very much like our step 1 and 2. I think that what I've said to the authors who said, well, we've published the guidelines, why are you doing the study? And the answer is really our study is a study of these guidelines, because there's really not a lot of evidence that these kinds of guidelines work yet. And I like to think that the study we're undertaking, although it was not intended to be that way, will be a test of these kinds of approaches and guidelines. This is worth looking up as a guideline, however, for you now, and so I have the reference here. So, you know, I think that the big question, this is almost my last slide here, is when I show this talk to some doctors who are not involved in the pain world or are not one of those 9 teams who follow these children, they say, well, that's not so complicated. All you're doing is what a medical student should do, which is do a good history and physical and order some tests. And my reply is, so why is it so damn hard and nobody can figure it out? So really that's the underlying part of this, is what is the barrier to making this happen? What really is just a common sense approach. I have already spoken to the idea that really the key to this lock may be the fact that we have this nurse who's very available to families in that interaction. And lastly, one of the things that we've been asking is about not just parent stress, but parent expectation. Do they think that this is going to work? What do they think is the cause of pain? Is there some kind of almost placebo effect that occurs when families engage with a team this way? So these are, I call them the meta questions for the meta physician. So I just want to acknowledge, as Tanja did, the wonderful team we have. It's actually probably longer than this. These teams tend to grow, but this is a wonderful group of people that I'm working with on the study. And it's back. I will turn this back over to Dr. Goubert.
Okay, thank you very much, Dr. Siden, for an interesting and thought-provoking presentation. So we now have some time for questions, and questions for the speakers can be typed in the Q&A box at the bottom of your screen. We have already a few questions there, I see, but to start up the Q&A part, I first would like to ask a question to Dr. Hechler. So, Tanja, you talked about intergenerational transmission of chronic pain in family. Can you tell us something more about what you think are the most important underlying mechanisms regarding this transmission of chronic pain in adults and parents to their children?
Yes, well, there have been excellent overviews out there. There's an excellent article from Amanda Stone and Anna Wilson on the familiar transmission, and the discussion is it social learning or what is the pattern behind it? I can tell you maybe my ideas with regards to the results we found. I found it quite interesting that we saw that parents with high severe chronic pain status catastrophized less than parents with less severe chronic pain. And my idea, and I have no data, I have some data on it, but not enough yet, is that maybe there is hope in that in our study, the majority of parents with high severe chronic pain status was in treatment. So it might be that the normal adult pain treatment decreases parental catastrophizing. I think this would be an excellent result, and I think we need to have more data on this. The other idea I have is that if the parents were in treatment, they were usually in intensive treatment, so they were away from their children. So this would be a mechanism where maybe parental catastrophizing decreases because of the local distance to their children. I think we need to figure out what is the pattern behind this.
Yeah, that's definitely an interesting area for further research. I see 2 questions here, and they are more or less about the same, and they ask a question to Dr. Siden. He talked about functional pain, and do you think that functional pain is the same as nociplastic pain, also according to the new IASP classification?
Yes, I want to say thank you to my colleague Alan Finley, and that's a very good point. The term, and Abigail had asked this, is functional pain the same as nociplastic? And the answer is yes, it is. The terminology around this, and I'm grateful that there is a new terminology, has been very challenging over the years. And but this is the kind of a central, basically as Dr. Finley says in his comment, it's neither nociceptive, you didn't hit your thumb, nor is it the classic neuropathic nerve injury to I like to think of as a peripheral nerve, but is happening in terms of the pain signaling, the pain processing areas of the brain. So that would be the answer to that question. So I hope that answers everybody.
Yeah. Okay. Until more questions are coming in, I have another question to you, Hal.
Yes, please.
Is there any evidence on the effects of multidisciplinary treatment targeted at parents or pre-verbal or non-verbal children? And is there any evidence that lowering distress in these parents may also have beneficial effects on pain and pain-related behaviors in these children?
So my answer to the question is that I'm not aware of any evidence. If one of the other listeners wants to type in something that they have, but I'm not aware. I think this is a very understudied population overall that creates a lot of distress for families and for clinicians. People have mostly focused on not very well designed drug studies, but looking at parent distress would be a very interesting opportunity. And it may be a secondary or a follow-up if we develop a relatively good guideline for how to rapidly and efficiently evaluate these cases to include more parent intervention, which we did not include in this particular trial.
So also in this population might be important to target parents and to include them in treatments. But there's no evidence yet.
There is no evidence yet, yeah.
Okay. So anyone who wants to comment on this, you're welcome. I have a question for Tanja. So you talked about interoceptive exposure treatments. Can you just explain to us how this is different to like more regular exposure treatments? And for which children would this kind of exposure treatment be most effective then, or more effective than regular exposure treatment that is more often applied?
Yes. Well, the usual exposure or graded exposure treatment is an exposure, for example, to increase activity in children with musculoskeletal pain. So what you do, you confront the adolescents with feared movements. I think people in the Netherlands and also Laura Simons have done excellent studies on this topic. This exposure is different because the cue, like the feared event, is different. It's not about feared movements really, but it's about feared internal bodily sensations. So you do that, you're not afraid of doing a particular movement, which would be more relevant for adolescents with chronic, with musculoskeletal pain, but you are afraid of a stomach rumbling or a tense neck or something like that, which then, and I think this is important, if you're frightened of these sensations, you might actually engage in maladaptive coping behavior, for example, taking medications if you not need to, right? And this is, I think, where we need to do something about this type of fear.
Okay, great. That's clear. Thank you. Then there's some questions coming in. First, a question for Dr. Siden. A question about whether are the behaviors observed in NCTPC also useful to observe in adults with advanced dementia? And does the primary form of caregiver anxiety or catastrophizing increase adverse outcomes?
So I'm going to answer these questions in reverse order, which is I think we've just spoke about. We don't know about what happens with primary caregiver anxiety or catastrophizing, but I'm hoping that we will start to get some inkling because we are studying the parents' emotional state throughout the randomized trial that I showed you, pre-intervention, during intervention, and then many months post-intervention. So we will have some information that I hope will encourage other researchers to look at the role of parents and where we may be able to intervene with them as well. Going back to the question about the NickPick, and I think these acronyms are terrible, but it seems to me, as far as I know, no one has studied the NickPick per se in the setting of advanced dementia. There are emerging, and I don't have time to type on Google while we're talking, but there are emerging scales for pain in nonverbal adults or adults with Alzheimer's disease. I've seen articles referencing that. So there's an emerging literature amongst geriatricians and gerontologists around assessing pain in adults. And I think that you can find that literature relatively easily about the development of scales. Someone had asked pre-meeting about the assessment of children with pain in cerebral palsy in primary school. And I would say if it's a nonverbal child, the two tools I would look at are both the NCCPC or alternatively to look at Ann Hunt's pediatric pain profile, the PPP. I think both are useful. In some ways, the PPP takes longer, but may actually be a little more useful if you have a lot of time, overtime with a family, you know, in a school setting to work with over many weeks and so forth. So that's the answer to those questions.
Okay, thank you. There are some other questions. One question, one attendee asks whether there is evidence that multidisciplinary residential treatment of children with chronic nociplastic pain is different from ambulatory treatments. I don't know who wants to answer. Who can answer this question? Tanja?
Yeah, I can, Harold, I can start and then you might maybe add. If I get it right, is the question, does it mean is intensive interdisciplinary pain treatment for children with chronic pain comparable to outpatient treatment? Is that like maybe the question about?
Yeah.
Because if yes, I really have to think, I cannot think the people from the German Pediatric Pain Center might have done some studies, but I cannot think of a study that has actually compared and randomized children to either outpatient or inpatient treatment and looked at treatment results. If you ask for the effects of treatment, we did a systematic review on the effects of intensive interdisciplinary pain treatment, and the effects were actually larger than what was found in meta-analyses on outpatient treatment. So I don't know if that answers the question, but I think that's a very good idea to study this issue further. But I'm not aware of any study. Are you, Harold?
This is moving a little bit away from my talk, but I think that, you know, Chris Eccleston in Bath had an inpatient pain program for a long time. I have a very vague feeling that there was a paper at one point comparing inpatient and outpatient treatment, but there may be other listeners who remember that literature much better than me and can correct us. But it is obviously for funders a very important question about the comparison of ambulatory versus inpatient treatment.
Okay, thank you. Then someone else is asking a question for you, Tanja. So you told in your presentation what the moderating effects are of parents with more chronic pain that catastrophize less. And she asked if you could a bit elaborate on that, what you found about this.
Yes. So what we found was, like, we had variance in parental catastrophizing, and our hypothesis was that the more chronic pain, the more severe the chronic pain of the parent, the more they would catastrophize. We did not find that. We found that the less severe the chronic pain, the more parents were catastrophizing, and the other way around, the more severe the chronic pain status of the parents, the less they were catastrophizing. And my thoughts on this is that the majority of parents with severe chronic pain were in treatment. So it could either be that the treatment decreased the parental catastrophizing, or the parental catastrophizing was decreased because they were not with their children because they were in treatment.
Okay, thank you. Then a question from a triage nurse, Jennifer Bernstein. She asks Dr. Siden if you can talk a little bit more about the frequent nurse communication with the parents of children with PIUO. Namely, support, empowerment, and teamwork. Her experience is that this model is very successful in helping to keep these children out of the hospital and establishing a trusting relationship and a high parent satisfaction. Can you elaborate a little bit on this?
I can quite simply, thank you. I want to say thank you to Jennifer Bernstein for that question, because it really is a part of our study question right now. Her experience is one that our original study nurse clearly reported the same thing. This nurse, the nurse at the time of the pilot study, made herself available by email, text, etc., to the parents all of the time, because she was also a ward nurse, and so she was up nights and would just answer questions. When we asked parents to reflect on the experience, when we did a post-study qualitative interview, they all said, wow, being able to reach the nurse made a big difference to us. So we've designed this study both to make the nurses very accessible at the 4 study sites, but in addition, we're studying the impact and the content of those exchanges. We did not design the study around that. And as those of you who do research know, you want to focus on one primary outcome at a time, but I think we're trying to gather enough data from this study that we could then do a later study about nurse-family interaction per se. And we actually have Jennifer Stinson on the study as well from Toronto. So I think that's another question. What Jennifer's experience is one that we hear as well. I don't know that anyone's ever studied it. And I think it needs to be studied in great detail about, does the nurse interaction make a difference? And if so, what are the elements? What's the magic sauce that really makes the difference?
Okay, thank you. Then I have another question for Dr. Hechler. So you talked about interventions directed at children of patients with chronic pain. So here are some questions as well about this suggestion. Do you know of teams that may actively include family-based support or family interventions for adults with chronic pain that include other family members to lower the risk that their children develop chronic pain themselves? Are there actually already any teams that are doing that?
Yeah, I think that's a very, very good question. I have to say at this stage, I am not aware of any, although I haven't done a profound research review, right? There is a study in psychiatry from 2012 where the psychiatrists who were treating adults were asked, do you know anything about the children of the adult who's actually in psychiatric treatment? And I think the percentage was below 40% who were able to tell anything about the children. So my answer to that question is I'm not aware of any adult treatment center who actually includes child variables, and I think we need to do way more on this issue.
And can you elaborate a little bit on how these interventions may look like? What would be important components of family-based intervention?
Yes. Yeah, I think what I would like to do next within my research is to design educational modules. Like if the adult comes into treatment and if he or she gives permission to talk to the child, the first intervention would be to talk together with the parent and the child on the chronic pain of the parent so that misconceptions can be decreased. I think this is a very easy way to do. Will only last for 45 minutes. They have been, like the therapists need to be trained and we need to have permission of the parents, but that would be, I think, the first starting point. Besides the assessment of the child's well-being, I think this should be done if we treat adults with chronic pain who have children.
Okay, so there's much work to be done there.
Yes.
Yeah. Okay. Then another question to you, Dr. Hechler. You have experience on body dysmorphic disorder. What's the incidence in patients and children with chronic pain, and are there any treatment options?
Oh my God, this is a very good question. There are lots of researchers in clinical psychology and even in Germany who are doing work on body dysmorphic disorder. If this person wants to send me an email, I can get her into contact or him. I don't know anything, any article on body dysmorphic disorder, maybe besides from children with morbus Sudeck. I think there have been studies on this area, but I can't tell you the authors at this stage. But I think this is a very interesting topic.
Okay. There was another question for Dr. Siden. So there was a question about the assessments of pain in children with cerebral palsy and autism in primary school. And the question was also, how can parents and teachers be supported and helped with assessing pain in children with cerebral palsy and autism? Is there any way you can have some suggestions?
In terms of support, one of the things that I would look for is there are some emerging sites for pain in children that really do speak to this problem of pain of children with nonverbal issues. And I think that one of the things that would be most helpful would be to begin to use assessment tools so that people begin to document in school what are the times of day that the behaviors are occurring, what seem to be the triggers for it, and remembering that one of the most important things is spreading the word to families that, you know, it's not that one must look very carefully and assiduously, as we are doing in this randomized trial, for these, they're really not hidden. They're just, people aren't looking in the right places for the nociceptive inflammatory causes, for hips, for scoliosis, for reflux disease, for seating. And these workups take a while, but once those are resolved, then thinking that pain, you know, you get to a place where you say, this pain may be nociplastic or central or really a form of irritability for the child. And really having ongoing long-term engagement with a clinician who's interested in this area and is willing to be patient and to take the time is very important. So I think my focus is for families to look for information from reliable organizations such as the IASP, Special Interest Group on Children, the websites of various pain researchers around the world, as well as getting the school to participate in assessment and finding a clinician who will be a long-term ally. Those are the best resources that I would say would apply in multiple settings, not just what's happening here in Vancouver.
Yeah, I think that's indeed will be very important. Thank you. There are no more questions coming in. So if there are no more questions, I would like to end this Q&A section by saying thank you to both speakers for your excellent presentations. And thank you also to the attendees for your presence and your interesting questions. And I now give the microphone back to Andrea.
Thanks, everyone. I would like to thank Dr. Hechler and Dr. Siden for their wonderful talks today, and to Dr. Goubert for moderating the session. We'd also like to thank all of our attendees. And as you can see on your screen, there's an upcoming conference hosted by the IASP SIG on Pain in Childhood in June this year, the 12th International Symposium on Pediatric Pain in Basel, Switzerland. The website is on this slide, and you can also go to the SIG page on the IASP website to view more information. And please consider joining the SIG if you have an interest in pediatric pain. There is also additional information and resources that you can find out about this year's Global Year on the IASP website. We will have a recording of the webinar available on the IASP Facebook page, and will also be posted on the IASP Global Year website shortly thereafter. Thanks very much for your participation.